Chapter 23, treatment of asthma and chronic obstructive pulmonary disease. Asthma is a chronic disease that affects the airways, producing irritation, inflammation, and breathing. Females are more likely than males to report that they have asthma, which I think is kind of interesting. Asthma is classified according to the severity of the symptoms. The three classifications of asthma are mild, moderate, and severe. So mild asthma is well controlled with as-needed reliever medication alone or with low-intensity controller treatment such as low-dose inhaled corticosteroids or leukotriene receptor antagonist. Moderate asthma, well controlled with low-dose ICS, long-acting beta-2 agonists, which we call LABAs. Severe asthma requires high-dose ICS, LABAs to prevent it from becoming uncontrolled or asthma that remains uncontrolled despite this treatment. It is not known exactly why some people develop asthma and others do not. However, there are risk factors that can increase the risk for asthma. A prime example is a positive family history of asthma or exposure to tobacco smoke. So I actually grew up having asthma as a child, into my 20s before I finally was testing non-asthmatic on a pulmonary function test. But I did my mom was a smoker back when I was younger and she smoked a lot. So I mean, and back when I was growing up, it was more like okay. So like we drove in the car with her smoking and yeah, so I don't know if that played a factor in it. None of my siblings have asthma. I was the only one, so I'm not really sure, but just kind of interesting to think about. Symptoms of asthma are linked to a progression of physiologic changes in the airway. Initially, the airway, the bronchial tube, and the bronchioles become irritated. This causes airway constriction, which makes the passage of air more difficult. Airways also become inflamed and swollen, further restricting the flow of air through the bronchial passages. Mucus production is increased above normal levels, which can also obstruct breathing passages. Airway constriction, inflammation, and mucus produce characteristic asthma symptoms such as coughing, wheezing, shortness of breath, and chest tightness. Symptoms may be mild or severe, life-threatening, and vary for each individual. There is a such thing as nocturnal asthma, and that's a condition characterized by decreased forced expiratory volume in 1 second. And that is increased airway inflammation is present along with exaggerated bronchial constriction. Cough at night may disrupt sleep. And in nocturnal asthma, lung function and anti-inflammatory hormones decrease and the release of pro-inflammatory mediators increases in the middle of the night according to the patient's circadian rhythm. Common symptoms of asthma are cough, wheezing, shortness of breath, chest tightness. Asthma triggers are things that can precipitate an asthma episode in individuals with asthma. An asthma episode is called an asthma attack. Examples of triggers are allergens such as an animal dander, environmental pollutants, cleaning fluids, mold, tobacco, smoke, and even cold air. Exposure to cockroach droppings and air pollution is linked to the rise of asthma in inner city youth, which is really interesting, I guess. So here's those all listed again. Scented products. So for me as a kid, anyone that would come around me, they had perfume or cologne on, I would immediately start sneezing and go into a sneezing fit. That doesn't happen to me now, but when I was a child with asthma, it did. They say strong emotional expression like crying or laughing hard and stress are irritants as well. One thing that's really interesting too is gastroesophageal reflux disease, so GERD, and laryngopharyngeal reflux can also worsen asthma symptoms. And again, that's just keep talking about myself, but as a child with asthma, by the time I reached my late teen years to 20s, I was actually taking medication for GERD. And it was prescribed by my asthma and allergy doctor because I had acid reflux related to asthma. And at the time, he explained to me that they're kind of related and kind of bounce off each other and cause symptoms and side effects with each other. So, kind of interesting to think about. Asthma symptoms can be managed with a combination of medication, lifestyle modification, and home monitoring of breathing using a peak flow meter and medication. Asthma has two main components: airway inflammation and acute bronchoconstriction. The drugs administered for the treatment and management of asthma are divided into two classes. Rescue medicines treat the acute symptoms and include short-acting beta adrenergic agonists such as albuterol. Maintenance therapy is used to prevent asthma episodes. Maintenance medications include long-acting beta adrenergic agonist, inhaled corticosteroids, leukotriene modifiers, mast cell stabilizers, and xanthine derivatives. The key to preventing asthma attacks, hospitalization, and death from asthma is reducing and preventing further inflammation. A peak flow monitor is a handheld device used to measure the volume of air exhaled and how fast the air is exhaled. A peak flow meter permits patients to manage their asthma, similar to the way in which patients with diabetes monitor their blood glucose levels to manage their disease. Low peak flow numbers signal that asthma is not controlled. Spirometry is a test that is performed to measure the volume of air that is expired, blown out of the lungs after taking a deep breath, and how rapidly the volume of air is expired. Albuterol is a short-acting beta adrenergic agonist and the most frequently prescribed bronchodilator. Other beta-2 and adrenergic agonists prescribed for the treatment of asthma include levoalbuterol, metapropionol, and terbutaline. B2 adrenergic agonists are commonly administered by oral inhalation using a metered dose inhaler, which we abbreviate as MDI, or nebulizer. Short-acting beta-2 adrenergic agonists relax bronchial smooth muscle, causing airways to dilate and thus reversing bronchospasms. To determine whether the contents of some metered dose inhalers are low, patients should check the counter mechanism on the inhaler. The counter shows the number of doses that are left. Short-acting beta-2 adrenergic agonists have a rapid onset of action and short duration of action. The onset of action for albuterol is within 15 minutes, and the peak effect occurs within 30 minutes to 2 hours. The duration of action of albuterol is 2 to 6 hours compared with its isomer, levoalbuterol, which has a duration of action approximately of 3 to 6 hours. And just a little tech note, if a patient is using their rescue inhaler or reliever medication more than normal excessive use, that means their asthma is not controlled. So there's another issue there. So we have the short-acting beta adrenergic agonist listed here. So for albuterol, there's quite a few different brand names. We have AccuNeb, which is like the nebulizer version, ProAir Respaclick, Proventil HFA, Ventolin HFA, and Vospire ER. So in the meter dose inhaler, Proventil, ProAir, and Ventolin are all the same thing. Then there is solutions for inhalation, powder for inhalation like Ventolin Discus and ProAir Respaclick. We have solution for IV use, syrup, and tablets. For the levoalbuterol, we have an inhaler and an inhalation solution. And for metapropionol, we have tablets and an oral solution. We do have some combination medications with albuterol and ipratropium bromide. That is Combivent or Combivent Rusvimet. Drugs that are intended for long-term use and take and are taken daily to prevent asthma symptoms are called controllers. The 5 class of drugs used for asthma prophylaxis are long-acting beta-2 adrenergic agonists, inhaled corticosteroids, leukotriene modifiers, mast cell stabilizers, and xanthine derivatives. So LABAs are contraindicated without the use of an inhaled corticosteroid. Single ingredient LABA should not be used alone. LABA use should be limited to the shortest duration of time required to achieve control of asthma symptoms and then discontinued. All right, so now we have our anticholinergics. So Tizora, Prasair, it's a powder for inhalation. Glycopyrrolate, it comes in a powder for inhalation in a inhalation solution and an oral solution. Hypertropium bromide comes in an inhaler and a solution for inhalation, so for nebulizing, and that's Atrova HFA. Tiotropium is Spiriva or Spiriva Respimat, and it's an inhaler and a powder for inhalation. Incruse Ellipta is a powder for inhalation. Then we have combination anticholinergics and long-acting beta-2 adrenergic agonist combinations. So this one here is not available in the US. We don't care about that. Bevespi Aerosphere is an inhaler. Udibron is a powder for inhalation. Styloto Respimat is either an inhaler or an inhalation solution. And Anorolipta is a powder for inhalation. And then we have our long-acting beta-2 adrenergic agonist. So Brovana, a solution for inhalation, so nebulizing solution. Perforomist and Foradil. So the Perforomist is a solution for inhalation, so for the nebulizer. And the powder for inhalation is the Foradil. For the Straverti Respimat, that's just an inhaler, and Servant Discus is an inhalation powder. Glucocorticosteroids are inflammatory drugs. They reduce the inflammatory response in airway cells, decreasing the mucus and swelling that may make breathing difficult. Glucocorticoids decrease the synthesis of pro-inflammatory substances that are released as part of the inflammatory response. The primary route of administration for corticosteroids used for the treatment of asthma is inhalation. However, they may be administered orally for more severe symptoms. Inhaled corticosteroids include beclomethasone, budesonide, cyclosinide, fluticasone, and mometasone. Some patients may develop an infection in the mouth or throat called thrush. However, the risk can be minimized by gargling or rinsing the mouth after administering each dose of medication. So we have our inhaled corticosteroids, Qvar Redihaler, an inhaler, Pulmicort Flex inhaler, and Pulmicort Ruspables. Those are inhaler and nebulizing solution. Zetona is a nasal spray. It's a really good nasal spray. And Alvesco Omneris is the other brand name. For fluticasone, we have Armonair, Respaclick, Arnuity, Ellipta, Flovent Discus, and Flovent HFA. And for mometasone, we have Asthmanex HFA and Asthmanex Twist inhaler. And also for mometasone, that is Nasonex, the inhale nasal spray too. We're not talking about in this chapter, but just want to throw that out there. Then we have combination products of long-acting beta-2 adrenergic agonists and corticosteroids. So like Dulera is formoterol and mometasone. Symbicort is formoterol and budesonide. Advair is salmeterol and fluticasone. And you can see all the different strengths for all of these in this chart. Leukotrienes are pro-inflammatory substances that are released as part of the inflammatory response. Leukotriene modifiers are administered to patients with mild asthma to reduce inflammation. A common ending for leukotriene modifiers is Lucas. Montelukast and zafirlukast interfere with the binding of leukotrienes on airway smooth muscle, reducing allergen-induced airway inflammation, airway relaxation, and edema. Montelukast is readily absorbed when administered orally. The maximum concentration of oral tablets is reached within 3 to 4 hours. Chewable tablets work faster, reaching a maximum concentration within approximately 2.5 hours. So we have our leukotriene modifiers like Montelukast, which is singular. It's available as oral granules, a tablet, and chew tabs. Accolate, zafirlukast is available in a tablet, and Zyflo is available as a tablet. Mast cells are released as part of the immune system's response to allergens. Cromolyn sodium is an example of a mast cell stabilizer. Cromolyn is administered for prophylaxis and does not control acute symptoms. It inhibits the degranulation of mast cells and prevents the release of histamine and the slow reacting substance of anaphylaxis. So for the mast cell stabilizers, we have Cromolyn, which is a solution for inhalation. And then we also have Spiriva, which is a meter dose inhaler or a powder for inhalation. The xanthines are one of the oldest classes of drugs used for the treatment of asthma. Theophylline occurs naturally in tea and is chemically similar to caffeine. A common ending for xanthine derivatives is phylline. Xanthines have bronchodilator and anti-inflammatory properties. The exact mechanism of action of xanthines is unknown. However, the drugs are known to inhibit the release of inflammatory substances and act on bronchial smooth muscle to reduce bronchospasms. So for the xanthine derivatives, we have aminophylline, a solution for injection, and theophylline, which comes in a capsule, an elixir, a solution for injection, and a tablet. Omalizumab is a monoclonal antibody that is indicated for the treatment of moderate to severe allergic asthma. It decreases the body's response to asthma triggers. Asthma triggers and environmental allergens can cause a hypersensitivity reaction that produces overexpression of immunoglobulin E, antibodies that cause asthma symptoms. A common ending for monoclonal antibodies is MAB. Omalizumab is administered once or twice a month by subcutaneous injection, and reslizumab is given by intravenous infusion once monthly. So we have them here. The Synquair is a solution for IV injection, and the Xolair is a solution for injection and a powder for injection. Chronic obstructive pulmonary disease, COPD, is a progressive disease of the airways that produces a gradual loss of pulmonary function. Emphysema, chronic bronchitis, and chronic obstructive bronchitis are all classified under the heading of COPD. The lungs and airways of patients with COPD are chronically inflamed and air sacs are destroyed. Various lifestyle and environmental factors contribute to the risk of developing COPD. Cigarette smoking is the leading cause. 75% of people with COPD are current or former smokers. Occupational irritants like asbestos, industrial chemicals, dust and air pollution. Viral infections can also aggravate COPD like RSV or adenovirus. The use of bronchodilators and glucocorticosteroids to reduce inflammation in open airways was described earlier. Usual doses administered for the treatment of COPD are listed at the table at the end of this chapter. Tiotropium is dosed once daily and is indicated for the treatment of COPD. Delivery of the prescribed dose of medication using an MDI is fast, but may be challenging for some individuals and is inappropriate for small children. It is not uncommon for a substantial amount of the drug to be delivered to the back of the throat rather than into the lungs when an A nebulizer is a device that converts a liquid dose of medication into an aerosolized mist that can be inhaled by normal breathing when used with a mask. A mouthpiece may also be attached to the end of the nebulizer and the mist inhaled using slow, deep breath. A spacer is a device that is attached to the end of an MDI. The drug is sprayed into the device's chamber and then slowly inhaled into the lungs. Some devices produce a whistling sound to alert the patient when inhalation is too rapid or is not controlled. So this is a spacer. There's a inhaler and the spacer hooked up to it. And now we have the summary of drugs used for the treatment of asthma and chronic obstructive pulmonary disease. So we've already went through all these, but we'll go through the warnings. So for these inhalers, we're going to shake well. Of course, we do not want to exceed the recommended dose because that means that something is not controlled. For the Foradil, that actually has a capsule that goes inside the inhalation device. So the patient should never just take the capsule by mouth. For the two Zora, discard that 45 days after opening the pouch. Shake well for Atrovent. And again, for Spiriva, that is another medication that has a capsule that goes inside of the inhaler. They should not swallow that. It should be inhaled through the inhaler. And Cruiselipta should be discarded 6 weeks after opening or when the counter is at 0. And a lot of these are shake well. For Montelukast, it says take with a large glass of water for chew tabs and discard unused portion of the granules within 15 minutes. For Accolate, the Zafirlukast, you should take that on an empty stomach 1 to 2 hours after eating. For the Zyflo, that should be taken with food within 1 hour after morning and evening meals. Swallow whole, do not crush or chew. The Cromolyn sodium should be shaken well. Aminophylline, swallow whole, don't crush or chew. Theophylline, take 30 to 60 minutes before meals with a full glass of water. Monoclonal antibodies, these are for the Xolair, should be refrigerated between 2 and 8 degrees Celsius or 36 to 46 degrees Fahrenheit. Discard reconstituted solution after 24 hours.